Hello, we're going to be discussing today health disparities and inequities, specifically focusing in the overall medical dental integration and oral health. My name is Francisco Ramos-Gomez. I'm a division chair of a preventive and restorative oral health sciences here at the University of California, Los Angeles, and professor in the section of pediatric dentistry. The overview of the presentation for today we're going to be defining the access to care for you guys so we can discuss what does it mean to every one of you, because it has different meanings, but to have a much more general perspective of that. Defining disparities and inequities. We're going to be discussing social determinants of health. We're going to be talking about life course framework based on age and risk, understanding your patient population, and finishing with some advocacy that you guys can do and get involved in the future as pediatric dentists. So let's start a little bit with overall frameworks of children's oral health. This is the Susan Fisher Owens framework the NIDCR has adopted. It was developed by a group of pediatricians and pediatric dentists looking at child-level influences, all the things that have to relate with family-level influences and community-level influences as well. So I want you to really picture yourselves in how do you really can make a big difference in the oral health of the child and the complexities that they're required in order to really achieve the best or optimal oral health for children in your communities, in the places you're going to be servicing. So let's start first defining access to care. Access to care means having the timely use of personal health services to achieve the best health outcomes, as you can see here. But really, if we tease out these pieces of access to care, we're going to be discussing a bit about coverage, about services, about timelines, and also finishing with the workforce, okay? So let's talk a little bit about coverage. These are the measures of coverage: the age, race, ethnicity, poverty status, and specifically the areas in the country that have better services or coverage than others, right? For example, here we can notice that all the states in green have significantly lower coverage than the US. So this is something that we should be aware of and see how we can improve the health for the families and the patients we're trying to reach. On the dental coverage piece, insurance benefits that help pay for the cost of visits to a dentist for basic or preventive services like teeth cleaning, x-rays, and fillings. So specifically, is your insurance plan and what is the coverage you have. You are insured, publicly insured, or privately insured, right? So these are the services. This is an example of age by sex percentage of people of all ages with a usual place to go for medical care. So this really follows trends in dentistry, in dental health as well, where you can see the disproportionate use of the percentage of people of delayed getting care, especially on the population of color. The African Americans as well as Hispanics are much in lower threshold than the other counterparts. And you can see the disproportion on the services as well, prescription medicines, as well as really waiting until urgent care is happening. Timeliness is really a very important issue to take into consideration, where we see adults who need care right away for an illness, injury, or condition, or the children who need care right away for an illness, injury, or condition as well. What do we mean by that? These are the children who need care right away for an illness, injury, or condition. And this is the part of the people that don't require those services right away, right? So there's a disproportionate utilization of accessing usual care, preventive care, instead of dealing with emergency care. The emergency rooms are really filled with people with a lot of dental emergencies, that all they will get is a lot of wait in their emergency rooms and really putting a tab on their Medicaid cost and just getting a prescription of antibiotic. They don't really take care of the root of what the problems are to begin with. So it's an important thing that we have to take into consideration, right? And lastly, the dental workforce, the workforce capacity. We have to have an ensuring well-coordinated, high-quality healthcare it requires the establishment of a supportive health system infrastructure. The key elements that we're looking for will be a well-distributed, capable, and qualified workforce, organizational capacity to support culturally competent services and ongoing improvement efforts, healthcare safety net for hospital admissions of vulnerable populations. As you can see in these graphs, these are some of the rates of dental workforce employment since COVID-19, right? So there's a decline on the workforce. The dental workforce is really declining throughout all the different, really the people that have been part of the team, right? With dental assistants, dental hygienists, the administrative staff, as well as the dentist. And utilization of care, we understand that even if care is accessible, utilization of the services may not meet expected levels or may be inappropriate based on medical necessity, meaning that the majority of the populations we're trying to reach or we're trying to serve do not really have the knowledge or the health literacy understanding of what they are really qualified for, what they can really get as medical and dental insurance specifically. So it's very, very important that we assist these families in understanding what kind of services can be provided for them and what that they can have access to before any medical or dental emergency. So I hope this really captures some of the issues of access to care that I want to bring to your attention. On the second part of this discussion will be defining disparities and inequalities, especially what do we mean by that. And there was a very exciting and interesting report from Healthy People 2020, where they really talk about health disparities adversely affects people's racial or ethnic groups, especially when you deal with religious, socioeconomic status, gender, age, mental health, cognitive, sensory, physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So we have to be very sensitive to these populations that are vulnerable in our communities, because we really are dealing with patches of third, fourth, and fifth world country within our urban cities here in the United States. So you guys have to be very sensitive and really understand the idiosyncrasy of the geographic location where you'll be located and address all these issues of health disparities. There's several potential readings that we'd like you to go and to see, where I'm just going to take a little bit of examples of what are these health disparities and what do they exist, and have some ideas of which are the populations that are hardest hit in the US. So people that are with low income, that are uninsured, homeless population is included into this as well. Members of a racial or ethnic minority group, immigrants, especially recent immigrants that they don't understand the system, or rural populations, right, who have suboptimal access to quality oral health care. So as a result, we see big inequalities, especially in dental outcomes. As you can see, these are untreated caries rates. Even though they're declining for some children, especially for minority groups, they're still very high up. In the incidence of early childhood caries, for example, it's a global epidemic, and it's very, very underreported, right? Because they're waiting for the hole on the molar to say, oh yeah, this child has cavities. I wish we had some surveys or some reporting of the ICDAS 1s and 2s, the non-cavitated lesions, which are the first really example of the progression of disease of children already with early cavitation or early signs of early childhood caries. So these are some other examples of health disparities that exist and health outcomes, especially the untreated caries rates, again, are declining in low-income children, as you can see, but they're still very much affected in some communities, especially the children that have visited the dentist in the past year, right? So what are the percentage of these children based on their race and their ethnicity? And you can see some big discrepancies between the white population as well as the difference between Hispanics and African Americans of communities of color. So what do we mean by health equity? We really mean the attainments of the highest level of health for all people. There's some very nice readings about oral health behaviors and availability of dental services among children and adults. They'll be in your packet of information. I hope you guys have read some of this information to really get into the health equity landfill and see really what does it mean, right? So it's very much related with social determinants of health. So health equities intend to reduce healthcare disparities in racial, ethnic, and disabled communities, addressing these SODH issues while incorporating the recommendations of Health Disparities Council and the Office of Health Equity. We still see that we have a ways to go to ensure equality versus equity. What equality means is that each individual or group of people is given the same resources or opportunities. Equity recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. And you can see here the difference, right? The equality, the sameness, and the equity is the fairness. And there's a difference, right? It's very, very nicely described in this graphic. So I hope you really think about and you ask yourselves, what is your role in equality versus equity? And where do you really play a big role in improving access to care and the equality for these dental services that on the communities you're going to be provided your patient care. So moving into this area of social determinants of health, I hope by now you're very familiar with those. It really has to highlight about education, access, and quality, about economic stability, social and community context. Neighborhood or geographic locations are really very important, especially now when we're seeing all these areas of climate change or food deserts, or areas where they really don't have the same appropriateness on services, especially related to healthcare access and the quality of services that we need to provide. You know, they really say where there is no dentist, what do we do where there is no dentist? And we have areas, especially not just rural, but urban communities here in the US where there are no dentists because they're all really pretty much conglomerated in the urban cities and not really in the outskirts or outside of these urban cities, bordering rural communities, and forget even about frontier communities that do exist in this mapping that we have. And for that, I really want to make a note for you guys to learn about allostatic loads. Allostatic loads is all what is related to the cumulative burden of chronic stress and life events. It involves the interaction of different psychological systems at varying degrees of activity. When environmental challenges exceed the individual ability to cope, then this allostatic overload ensues. So pretty much, you know, you have these major life events with environmental stressors, the individual difference that exists, and our psychological, physiological responses on this perceived stress that exist in these behavioral responses. And that has very, very much a determination in the stress that this will really affect in poor health outcomes in general. And there's a lot of research done on this, and situations that may lead to the development of allostatic loads overload are exposure to frequent stressors that may determine a status of chronic stress and repeated physiological arousal, lack of adaptation to repeated stressors, inability to shut off the stress response after a stressor is terminated, so allostatic response not sufficient to deal with the stressors. So we know, for example, that cardiovascular disease, diabetes, obesity, mental health issues, they're all related about these allostatic load stressors, and oral health is a part of it as well. So I want you to be cognizant about this very important issue that really affects our communities, vulnerable communities that we're dealing with. On this aspect of social determinants of health, the World Health Organization defines it as the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So some of the specific issues that our American Academy of Pediatric Dentistry, the policy, we have a policy on social determinants of children's oral health and health disparities. And the APD does recognize the influence of social factors on children's oral health, including access to care, dental disease, behaviors, and oral health inequalities. And they really have a specific role for us as healthcare professionals and policymakers about what can we do about it. So it encourages the implementation of oral health promotion strategies and clinical management protocols, right? That we will address some of these social determinants of health, and to really bring the light into these communities, especially for health professionals, researchers, and educators to really focus in addressing oral health inequalities. Some very, very wonderful examples of successful interventions addressing these social determinants of health. We can really think about telehealth, which is really something after COVID, we've been able to really have some better grasp about the benefits of bringing pediatric dentistry to people's households, right? To their living room, their dining room, their bathroom, where they are very much easily to reach, where they'll be more comfortable to understand messages, to really address the risk assessment and counseling anticipatory guidance that we as providers need to do, especially in a non-threatening environment where they don't have to deal with a 2 hours traffic, for example, to get to the dental clinic, to pay parking, to get to the visit, and to be all stressed out, especially if they have no other care for their other children and siblings, right? So we're trying to minimize the stressors of these families by addressing the issue of telehealth with great success, by the way. We need just to talk about reimbursement for these telehealth visits, which I hope in the future it'll be a very parallel to clinical care. You'll have also a virtual room where you'll be promoting these telehealth visits. School-based programs, as you know, they show great success in expanding preventive care and education to children in lower income communities. Fluoridation, it's a given. We have to keep fighting and advocating for fluoridation of the water. Not all the areas are fluoridated, as you know, and also really make a distinction between fluoride in the water system as also topical fluoride, and this whole fear of fluorosis that people very much misunderstood. So things that we have to address. Dental sealants or protective restorations for both for primary and permanent dentition will be essential for the preservation of the primary teeth, as well as a mixed dentition and the permanent dentition as well. Obviously, outreach and education are some things that you really need to emphasize, especially working communities, working with WIC and with Early Head Start or any of the programs that exist there. And daycare will be an essential part of the role you have to play. And now this new era of community oral healthcare workers that can be integrated into the dental team, especially working with between the providers and the families. These community healthcare workers will be an incredible resource for cultural sensitivity, language barriers, really dealing with your no-show rates. I mean, all these benefits that are proven to be so effective in community healthcare workers and be integrated into your dental team will be essential. And lastly, but I think the most important is really to follow the APD and IAPD and WHO and all these policies related on the H1 visit, right? The first birthday, first tooth in the mouth, and the first visit should be at that stage where we can really assess the child with risk assessment. Whatever risk assessment tool you want to use will be essential, and also the counseling and anticipatory guidance and motivational interviewing, right? To address the issues of diet habits, and also poor oral health and nutrition. So it's very, very important that you address also these issues of diet, nutrition, and hygiene, right? The last thing that touches your child's teeth should be the use of fluoridated toothpaste, which is a message that we need to really in unison convey to our parents, especially at this early age, which is very, very important. So addressing at a state level, for example, in Michigan, there's a Medicaid medical and dental managed care contracts that now include requirements to address social determinants of health. among enrollees. And some of these states are really also adding the community healthcare workers training curriculum and also benefits and even reimbursing for telehealth visits and community healthcare workers. So it's something that, stay tuned. We hope that all states achieve this degree of cultural sensitivity and addressing specifically oral health literacy in the communities we're trying to reach. Moving a little bit about life course, I really want to emphasize that the era that HHS, the Health and Human Services, and all of these very much important groups globally, from WHO to PAHO in the US and the HHS, have adopted this across the life course ecological model of health, where it's really based on environmental conditions, policies that are global, national, state, and local levels, really understanding living and working conditions of the communities we're trying to serve, the social, family, and community network, and individual behaviors, right? It's pretty much a very specific protocol based on age and the population and individual risk factors that they have, really looking at mother and child diet impact, especially at that golden age, where the pregnant women are very much in tune to look for their own health as well as for their babies, and to really address some of the disparities that might include through this life course, right? So this is just a very nice example of all the areas that we can look, especially from pregnancy, infancy, childhood, adolescence, adulthood, and older adults, right? So it's based on age and based on risk, and really dealing with all these issues of enabled society and environment with strong and supportive communities and confident and capable families. And these are the areas that we play a big role for really following into life course. And we're going to be moving now to understanding your patient population. So we have some great resources, especially with the ADA, the American Dental Association. They have a wonderful Health Policy Institute where we really have a lot of information, and we have all these policymakers and advocates and clinicians to really have specific, accurate data. So these are some of the resources that the Policy Institute has, with the number of US dentists that are now practicing in the US, and unfortunately declining based on race, as well as the US population. We by no means match the demographics of the population we're trying to reach. So this is something that we need to bring to your attention, right? We need to make an extraordinary effort to enroll, to recruit, and retain some of these providers, especially from very diverse backgrounds. So this is just an example of some of the data on racial and ethnic mix of the dentist workforce in the US. And this is the amount of dentists, of white dentists, Asian, Hispanics, African Americans, and others, right? So you see the disproportion of these dentists related to the communities we're trying to reach and to serve. So these are some of other great, amazing resources of the ADA Health Policy Institute. For example, these are the reasons for not visiting the dentist more frequently among those without a visit in the last 12 months. So we all thought it was costs, 62%, but there's a lot of fear, for the dentist, 13%. Inconvenient location or time, the time to commute to try to get to the dentist, 18%. Trouble finding a dentist, 12%. No original teeth, no perceived need, no reason, and others. But also the fact that 29% of low-income adults avoid smiling to the condition of their mouth and teeth, and also 19% of low-income adults reduce participation in social activities due to the condition of their mouth and teeth. This is something that really has huge social impact in our families, in our patients, and the people we're trying to reach, right? 38% of high-income adults experience pain due to the condition of their mouth and teeth. That's pretty severe. 38% of high-income adults experience dental pain. So it's just something to reflect about and see how you guys can be agents of change in this improvement for access to care in the future. So some of the overall conditions of the mouth and teeth, pretty much the message is that 1 in 5 low-income adults say their mouth and teeth are in very poor condition. And this is something that we have to really take into consideration. And again, it's so important that you guys are so cognizant wherever you end up being, wherever you end up practicing, there's data available for you. An example is this Neighborhood Atlas Area Deprivation Index, where living in a disadvantaged neighborhood has been linked to a number of healthcare outcomes, including higher rates of diabetes, as I mentioned you earlier, cardiovascular disease, obesity, increased utilization of emergency health services, and earlier deaths, right? So every neighborhood has a specific ADI, this Area Deprivation Index. And this is just an example for California on the areas where there is no healthcare services, where there are those deserts, right? There's deserts, not just food deserts, but also deserts on care, or really lack of forget about even dental medical support systems. Most of them are in the school systems where they get this care, or in WIC or early Head Start. So it's important that you're aware of what is your ADI in your area where you're going to be practicing. So this website is a great resource. It has great in order to freely share measures of neighborhood disadvantage with the public. So you guys should really participate in getting some of these resources available for you. So this is the part where I'm going to leave with you some exercises that you can be doing. So one of them will be to go to this neighborhood atlas to look areas where you're practicing or you're planning to practice agents of change to improve access to care, quality care for those communities, especially on the preventive side, right? All the things that you can do to prevent one visit ECC, their child care, so things like growth and development of these children to get their optimal health in the future, right? Another very important exercise we suggest what we like you to do is this poverty simulator exercise. It's kind of very fascinating, the different really decision making that you have to do, right? And to ask yourself, what was the most difficult part of this exercise? Did you face any ethical challenges while doing this, which is a very important part of this equation, right? What is our role in decision making for the services we provide, and also for the decision making that families have to do when there's really lack of resources available? What impact does the exercise have on how you will approach patient-provider communication in the future? And what impact does this exercise have for you to approach advocacy in your professional practice, right? Most of this is a course for advocacy and policy, and this is something that you guys should be more aware and sensitive about. And moving along on other resources, the Healthy People 2030 framework is a great resource. We have very specific goals in some very specific objective areas. The whole idea to attain healthy, thriving lives and well-being, free preventable diseases, disability, injury, and premature death, to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all, is really our main focus and our main mission, right? Again, I want to repeat this to you: eliminate health disparities, achieve health policy, and attain health literacy to improve the health and well-being of all should be our purpose, our focus. Some of the objectives areas, and you can go, I don't have time to go through all of these resources, is for you to do your interactive work and to go in there and check on the oral conditions, and nutrition and healthy eating, healthcare access and quality, children, tobacco use, and opioid reduction, right, will be also a very important area, which I didn't really mention here, but I really want to emphasize this effort to really bring the opioid reduction to minimal in the dental world should be essential. Another great resource is our National Institutes for Dental and Craniofacial Research. There's an update of the 2000 Surgeon General Report on Oral Health, which is that one in 2021, which I strongly recommend that you see this new report that was released already by NIDCR in 2021, and you can really get great information on all the latest on these events. So finally, in really addressing advocacy for disadvantaged populations and resources, we went through the data. You need to have very specific data that carries rates in your communities you're trying to reach or you're trying to be. In California, we have this survey from 2018, 2019, thanks to our wonderful oral health department for the state with Dr. Jay Kumar leading that group. And also you have the American Academy of Pediatrics Advocacy Guidance, the AAP, has amazing resources that you can go specifically on this advocacy for care coordinators, patient navigators, community oral healthcare workers, patient navigators, promotoras, or interprofessional education and training. The AAPD has something very similar as well. Well, these are the tools that we have. And as you know, the AAPD has also the advocacy day. Usually it's once a year around early March, where we all go to the Hill to really bring the issues related to advocacy. And part of this training on your advocacy course is to be prepared and to give you some of the resources available so you can go to Washington, D.C. with the knowledge, the information, the appropriate understanding of what this labor of love really represents, so we can really be there, be the children's voice. And with that, we have some additional resources on this that I leave them for you. And with that, I want to thank you so much for your presence today. I hope this was helpful. Please send me any questions or any things you want for clarification. But I'll leave you with this challenge, which is to be really these advocates for children's oral health. You guys, we want to ensure that you'll be not just the best pediatric dentist in the country, in the world, but also the best advocates, because these children need your voice and we need you to make the difference. Hope you have a wonderful day, and thank you very much.